All right, so we're continuing on with Unit 2, Evidence-Based Public Health. And now we're going to talk about etiology, or what are the causes? What are the things that are contributing to a current disease or condition? What is causing the problem? Now, the first thing that we're going to do to help us generate some hypotheses, some perhapses, some maybes, some ideas about what's causing the problem is we're going to look at the distribution of disease. And the three questions we're going to ask here are who, where, and when. Who is getting it? Where do they live? And when are they getting it? And then we're going to use that information to look for what's called group association. So these are kind of broad observations that we make us go, maybe this is something. So the book gives you a good example of how chimney sweeps back in the Victorian days, they were found to have really high rates of cancer. And then they were like, maybe being exposed to all that soot for a gazillion hours a day is bad for your health, right? So that helps generate a hypothesis. Similarly, after smoking rates increased significantly in the United States in the 1900s, a couple of decades later, we saw a huge increase in lung cancer. I wonder if they could be related. Or perhaps there's a whole bunch of stout students who got sick with nausea and vomiting, and they all ate, or a bunch of them ate at North Point. I wonder if there's something there. So those are group associations. They give you possibilities to explore. And of course, one of the most famous group associations, my favorite, Dr. John Snow, the ghost map, the cholera outbreak in London. So again, right, so he noticed he did the who, the where, and the when it was all part of the same outbreak. So figuring out where things are happening, who is being impacted, and when, and looking at those patterns can help you identify, I might be onto something here in terms of what's causing it. But we have to be careful because these are just hypotheses. So group associations don't mean that necessarily that is the cause, right? It could just have likely, if it were a different type of infection, been that there was something in the air that was causing that cholera epidemic because they were all geographically in the same place as opposed to using the same well, right? And a lot of doctors of the day thought it was. So we think about the fact we saw previously that young adults get chlamydia at much higher rates than the general population, right? So 1 in 67 versus 1 in 300 something. Is that because younger bodies are somehow more vulnerable? Is it that you haven't developed immunity? Is there something about your youth that makes you at higher risk? Actually, it's just you tend to have more unprotected sexual partners, right? So you have to be wary of things because correlation doesn't always imply causation. And the book gives a nice example of talking about how states that have more drowning deaths also have more ice cream consumption. So like, is ice cream causing people to drown? Well, no, it's just that both of those things are going to be more prevalent and more common in places that are hotter, right, where it's warmer. So we have to be wary of group associations. They are the first step in saying, I have a hypothesis here that might be onto something. But then we need to do further work to actually establish whether something is a contributory cause. So as we go to establish contributory cause, right, we've identified a group association, we have a hypothesis that something might be at play here. We need to investigate further, and there's 3 requirements that we have to meet. So the first one of those is that the cause is associated with the effect at the individual level, right? So did everybody who drank, from the Broad Street pump get sick, right? Or did most of the people get sick? So look at the individual level rather than just the population. So for example, when we talked about the smoking, when the textbook talks about that, yes, lung cancer rates in the United States went up at the same time that smoking rates had gone up, or a couple decades later. Were most of the people who got lung cancer smokers? Well, we have to figure that out, right? We have to actually see that it tracks at the individual level. We also have to make sure that the cause precedes the effect in time, right? In order for it to cause it, it had to have come before. So we need to establish that, kind of the chicken or the egg. We've got to figure that out. And we also want to see if changing the cause, the potential risk factor, alters the effect, right? So if we change that, does it actually impact the disease at all? So what's really kind of cool about this is that you don't need to understand the scientific mechanism in order to be able to identify contributory causes, because these are the ways we identify contributory cause. You might not know why the soot in the chimneys is causing cancer. You may not know the cellular mechanisms by which genetic mutations are happening, resulting in a neoplasm. You don't need to know that in order to identify, inhaling soot all day increases your risk for cancer, so let's do something to improve people's health by having them not be in soot all day, right? So that's kind of cool, is that you don't need to understand everything fully in order to potentially make a big difference. All right, so to meet those requirements, we're going to have different types of scientific studies that we do. So that first question, is the cause associated with the effect at the individual level? In order to answer that question, the type of study that you're most often going to see is what's called a case control study. So what we do is we identify cases. These are people who have the disease or the condition. Those are our cases. And we're going to compare them to people who don't have it. We're going to compare it to controls. And if we find that the people with the disease were more likely to have this potential risk factor than the people who don't, then it's possible, then maybe we're onto something, right? So we're asking ourselves, what's different about those cases compared to the controls, right? Of all the kids in Victorian England who got cancer, what did they have all have in common, or were more likely to have in common compared to the kids who didn't get cancer? So let me give you a couple of examples. All right, so let's use the students who ate at North Point who are getting sick. So if we look at a bunch of students who got sick, so let's say we've got 10 students who got sick, and then we compare them with 20 students who didn't, and then we ask them where they ate. And if 70% of the cases, those who got sick, ate at North Point, and only 10% of the controls ate at North Point, well, then we might be onto something, right? There might be something about the food at North Point that resulted in this illness. So that's a potential contributory cause, right? We still haven't fully established it, but then evidence starts to mount. It's worth considering and pursuing further. Sunburn. So let's imagine that we have a family and a bunch of people got sunburned. So let's say 5 family members got sunburned and 10 didn't. And of those 5 who got sunburned, 80% of them used this special new organic sunscreen, right? And among those family members who didn't get sunburned, only 30% used the organic kind, and the other ones used, I don't know, copper tone or no ad or something, right? So then maybe that sunscreen is a risk factor for getting sunburn. Maybe it was less effective than the other. So again, for any condition, there's usually multiple factors involved, right? Maybe those family members just had paler skin and they're more vulnerable to sunburn to begin with, right? So the presence or absence of a risk factor is almost never a guarantee one way or another. It's not what's considered either a necessary or a sufficient cause. It just increases the likelihood that you might have the condition or might develop the condition. So that's to answer the first question. Do we see that association at the individual level? That's the case control study, comparing those who have the condition with those who don't, and looking to see what's different between them. Our second study, does the cause precede the effect? We're going to do what's called a cohort study to do this. Now, a cohort study is where you get a big group of people, you sign them all up to do this study, and you want to enroll some people who have the potential contributory cause, the potential risk factor, and some who don't, and follow them over time and see what happens, right? So maybe we're going to enroll everybody who eats at North Point and a whole bunch of people who don't eat at North Point, and we're going to follow them over time and see if there's a difference in who gets sick with nausea and vomiting versus who doesn't. So one of the huge and most influential studies that we ever did in the United States, and it's still ongoing, you'll see a media assignment about it, is looking at adults with various health conditions and following them over time and seeing what develops. So let's say we follow adults with high cholesterol levels versus those with normal cholesterol levels and see how many in each group go on to develop heart disease. And so this is the Framingham Heart Study that is still taking place in Framingham, Massachusetts. Basically, like a huge segment of the population of the town is just like, yeah, we'll enroll in this study and you can study us for decades and decades. I think it's in its like third generation now. So we're following people forward over time. And so let me show you some data from that study. What we're looking at here is lifetime risk of coronary heart disease. So blockages in the coronary arteries that can cause heart attacks. And the blue are male-bodied people and the orange are female-bodied people. And what you can see right away is that there's a big difference between men and women in terms of their risk for heart disease. That is a very true thing, which is why they separated them out for the purposes of this study. And let me just show you a few things here. Let's do a little highlighter. So here is total cholesterol less than 200. So these are people with normal cholesterol levels. And you can see that around 31% of male-bodied people did at some point in their lifetime develop coronary artery disease, coronary heart disease. But of the people whose total cholesterol was over 239, look at this, like 57% of them, right? So much higher likelihood of developing heart disease if you had high cholesterol at baseline, right? So the cause preceded the effect. This is a cohort study, groups of people, some with risk factors, some without, over time. And we can actually even measure the strength of that, like how much does that risk factor seem to be contributing to the disease, with something called relative risk. So relative risk, it's relative, right? So we're looking at the risk in one group versus the risk in another group. So we're going to see how much more or less likely you are to develop a disease based on a certain risk factor. So let's use this data again. So that kind of 31% for normal cholesterol versus I think it's maybe about 57%, right, for high cholesterol. So how much higher is the risk? So to calculate relative risk, you're going to look at the incidence of those with the risk factor and divide it by the incidence in those without the risk factor. Okay, so here we've got 57%. We divide it by 31%, and we get 1.8. So that means that the male-bodied people with high cholesterol were 1.8 times more likely to develop heart disease than those with normal cholesterol, or 180% more likely. So 1.8 times more likely. So that's kind of a lot, right? That's a big deal. So again, this is an example of a cohort study following people forward over time to see if the cause precedes the effect. Requirement number 2. Requirement number 3 is, does changing the cause change the effect? And the best way to do that is to do what's called a randomized controlled study. So what you're going to do is you're going to take a big group of people and you're going to randomize them into 2 groups. One group that gets exposed to the potential cause or treatment, and then the other group that gets either not exposed or is given a placebo, right? So you've got the exposed group and the control group. And then you're going to see what happens to them. Now, this randomization is something that you can do to make sure. So remember when we talked about the sunburn and like, oh, well, maybe some people were really pale skin and so they were already at increased risk. So when we randomize, we're going to make sure, if we were going to do that study, that just as many really pale, burn easy people are in the exposed group or the experimental group versus the control group. Now, as you can imagine, if I already suspect that type of sunscreen, that organic sunscreen, sorry, no shade to organic things. I use a lot of organic products, but sometimes they're not as effective, right? If I already suspect that organic sunscreen doesn't work very well, you might be feeling a little uncomfortable. You might be like, well, Dr. Hall, like that's kind of mean to purposefully give a whole bunch of kids a sunscreen that you don't think is going to work well, send them out to the sun and see if they get burned. So yeah, so randomized controlled studies, when we're looking at something that we think we have, we have a hunch, we have some data, we have some evidence to support, we think it's going to increase your risk of a disease, usually it's not ethical for us to say, okay, so we're going to have you do this thing that we think is going to make you sick, right? So oftentimes it's not ethical to randomly assign people to an exposure group that we think is going to put their health at risk, right? Like, okay, you guys go drink from the Broad Street pump and you guys go drink from another well and we'll see what happens. Like, once we think that that's actually making people sick, it's not ethical to do that. So what's interesting in public health is that we very, very rarely will have randomized controlled trials looking at risk factors for disease. It's just not ethical. We will, however, have randomized controlled trials looking at interventions and treatments, because a lot of times, like if we truly don't know if they're going to work, or we need to have really good data on whether they're working and exactly how well they're working, then it is ethical to go ahead and do those experiments. So let me give you a few examples of looking at interventions or treatments. So the first one I'm going to give you is a study that was published in 2023, but the data was collected in 2021, looking at one of the COVID vaccines, actually, Novavax, which is not what most of you got if you got a COVID vaccine. But anyway, they looked at just over 2,000 young people aged 12 to 17. And they randomized them. So they allocated almost 1,500 into the vaccine group and almost 750 into the placebo group. So they actually got a placebo, meaning they actually got injected with just saline, like nothing. It's no active ingredients, right? So a placebo, because if somebody thinks they got a shot, sometimes they'll behave differently. So you have to make it so that the patients have no idea, the study subjects have no idea whether they got the actual vaccine or whether they got a sham, a placebo. So they randomized these kids, so they made sure they had the same number of different ages and different types of conditions that might impact their underlying risk, so that the two groups were very similar in terms of all those things. And what they found, they followed them over time then to see who actually got infected with COVID. And there were just 6 in the vaccinated group. So that's 6 out of 1,487, which if you do the math, right, set up your ratios and cross multiply and divide, you get 403 per 100,000 was the incidence. And for the placebo group, 14 out of a smaller denominator, out of 745. So the incidence there is 1879 per 100K. I made a little bar graph so you can kind of see that visually. And so you can see absolutely, right, those who got the placebo had a much higher risk of infection than those who got the vaccine. And remember, these people didn't know which one they got. But if we calculate relative risk for the vaccine recipients, right? So if you got the vaccine, your relative risk was 0.2. So if your relative risk is less than 1, that means you're less likely. So 0.2, so they had 20% the chance, or they were 80% less likely to get COVID in this particular study, which we call 80% effectiveness against infection for a vaccine. So that's pretty darn cool. So if you look at the vaccine as a protective intervention, then the relative risk is 0.2. It reduces risk by 80%. You can flip it and you can say, well, being unvaccinated is a risk factor that increases your likelihood of disease, right? You can flip the numbers, and that's 4.7. So the unvaccinated kids were 4.7 times more likely to get infected. So if we were looking at that as a risk factor for disease. So I just want to take a moment to say that for the COVID vaccines are actually one example of using randomized controlled trials at quite a large scale. I know a lot of people are like, oh, they just rushed it. They didn't study these vaccines. They did. Actually, they did. We have more randomized controlled data on the COVID vaccines than we've ever had for any vaccine in human history, like, period. So over 35,000 adults participated in randomized controlled trials of the COVID vaccines. Now, I'm not saying COVID vaccines can't potentially cause problems, right? They can, but we also have really good data that shows that they were really quite effective, at least in the beginning. So what we're looking at here in this image is from a meta-analysis of a whole bunch of randomized controlled trials of COVID-19 vaccines. So looking at kind of all those 35,000 people that were all these other different studies. And in blue, you see the effectiveness of the vaccine. In orange, you can hardly see it, is the effectiveness of placebo, right? So they're always comparing against something that's controlled. There's a control, right? We're just not looking at how many people who were vaccinated got infected. We're comparing it to how many people who got placebo. And so you can see these vaccines in the, you probably can't read, these go up to 4 weeks. So in the early days, within the first 4 weeks, they were highly, highly protective against getting infected, which also meant they were highly, highly protective against spreading the infection to other people in the first 4 weeks, and in fact, probably in the first 3 months. Okay, now, alas, we know now that this protection wanes over time, and it was silly to think that it wouldn't, actually. But I will tell you that the vaccines do still help reduce your risk for severe illness, and we'll come back to that later in this talk. Let me show you another randomized controlled trial of a treatment. So in Framingham, they identified that high cholesterol increases your risk for heart disease. So then the question becomes, does lowering your cholesterol reduce your risk for heart disease? And you'd think that's a slam dunk, but sometimes it actually doesn't work that way in medicine. So you actually have to do the studies. So this is some data on a cholesterol lowering drug called ezetimibe. I don't know how they come up with these names. But anyway, they looked at the incidence of heart disease and stroke, basically. And here's the number and the percentage of people in the control group. So these people got placebo. And then these people all got the medicine. And this is how many people and what percent that was. So 7.8% of people in the control group had heart disease or stroke, and 5.2%, which is lower, right? You might think, oh, 5.2% versus 7.8%, is that really significant? So if you do the relative risk and you say, what's the relative risk for those who got the medicine? It's 0.66. Now, they use the term hazard ratio here. It's basically the same thing. So that means that they were 34% less likely to get heart disease or stroke compared to the people who took the placebo or the sugar pill. So that's pretty powerful, actually. So that was really good. So just another example, most trials of drugs and vaccines in the United States will be randomized controlled trials because that gives us the best data that we could possibly get. But remember, it's really hard to get those for understanding causes of diseases because we don't want to intentionally expose somebody to something that we think might make them sick. So what do we do? Because requirement 3, right, altering the cause alters the effect, we need some kind of randomized controlled trial. And we often can't do that when we're trying to understand the causes of disease. So there are other ways that we can get more support or strength to suggest that we're really on to something. So when you need more evidence, where do you get additional support? So first is strength of the relationship, and that's where that relative risk is going to come in again. So let me just show you some more COVID data, because there's so much COVID data that has come out over the last 4 years. It's just lots of pretty graphs. Here we go. All right. So this is looking at relative risk of COVID infection in the United States. Now, this is in 2021, so this is old data, and this is before the vaccines really started wearing off. So these were infections in unvaccinated here, and this is the rate per 100,000. Now, so what they do is they calculate of all the unvaccinated people, how many got infected, and then calculate the incidence, and out of all the vaccinated people, so you have to know how many people are in each group first, and then calculate the incidence for each one. So your denominator is different, right? And here's your fully vaccinated. And what they found is that the incidence rate was 5 times as high in people who were unvaccinated. So they were 5 times more likely to get infected than people who'd been vaccinated. The death rate, interestingly, in those early days, so this is November of 2021, so still relatively early in the pandemic, was 13 times as high. So the relative risk of death for being unvaccinated was 13, right? So not good. And then this is hospitalization data for New York City. New York City did a really great job. Their public health department is amazing. They did a really great job posting like in the moment, up to date data about cases, hospitalizations, and deaths. And here they have broken out people who are unvaccinated. And again, these are incidents, so it's controlled for the population. Out of all the unvaccinated people, how many got hospitalized? Of all the vaccinated people, how many got hospitalized? So looking for those different populations, vaccinated versus unvaccinated. And you can see that obviously the unvaccinated people had a much higher rate of hospitalization than the vaccinated people. You can also see that the citywide incidence rate, like everybody all together, is close, very close to the vaccinated people. That's because most people in New York City got vaccinated, right? They'd been hit really hard by the pandemic. They saw the freezer trucks being used as temporary morgues, right? They got it. They got vaccinated. So this was in the early days when we knew the vaccine was still very highly effective. Let's look a year later and see what the data looked like. Oh, they published that too. So this is the same thing. The graph looks a little bit different and you can't see the key, but these are the unvaccinated people and these are the vaccinated people. So again, we're seeing a significant increased risk for, this is hospitalization again, for unvaccinated versus vaccinated. So let's compare the 2 years, because why not? Let's see if we get a consistent relationship or if it changes. So here's the data. So I picked these dates here, right? So they're basically a year apart. Obviously, they're each going into a wave of COVID. And so in 2021, as you can see, the unvaccinated, I tried to read the graph as best I could. So approximately 19 per 100,000 were hospitalized and vaccinated 4. So the relative risk was 4.75. Now in 2022, down here, it was worse, right? More people were getting hospitalized than had the year before, right? Definitely worse, like twice as high. So it seems like maybe the vaccine is not as good, or is it that it's just a more severe illness? Like what's going on? And so if we calculate the relative risk, we see the difference is still 5, right? So the vaccine is still really protective against severe illness. And this is even in 2022 when most people's vaccines are starting to wear off, or some people are getting boosters, but not everybody. So, but then I was interested, I was like, okay, well, do we have any data that's later than that? And I found this. So these are death rates by vaccination status in the United States from 2021, so October 2021, all the way up to April 1st, 2023. That was the most recent data I could get for this lecture. Orange is unvaccinated. So look, in the early part of the pandemic, before anybody had any natural immunity, right? Natural immunity is infection-based immunity that you get after you've been infected with something and survived it, right? And so what we're seeing here is all those people who didn't survive their initial infection. Now, granted, some of the vaccinated people didn't survive their initial infection either, but they had much better odds of surviving, right? Their rate of death was much, much, much lower than the unvaccinated folks. Now, as we follow that over in time, we see that maybe vaccine effectiveness is wearing, or probably the fact that pretty much everybody has been infected at least once, if not more than once, with COVID by now. So you have natural immunity and you've survived those previous COVID infections, which is also like going to kind of get rid of some people who would otherwise die again. They already died the first time. So we see now that the advantage to vaccination is a lot smaller, right? The difference between vaccinated people versus unvaccinated is much smaller than it used to be. And I was interested to see how much smaller. So remember earlier that New York Times, it was a 13 times, the relative risk was 13 times higher for unvaccinated versus vaccinated for death. So I thought, okay, let me get the data. So I actually downloaded the data table for April 1st, 2023, which was the most recent I could get. And you can see here that we've got 0.61 was the death rate for the unvaccinated and 0.17 for the vaccinated. So I do my relative risk, so I divide the one by the other, and it's 3.6. So unvaccinated people were still more than 3 times likely to die from COVID than vaccinated people, even as recently as the spring of 2023, that's pretty powerful. Now, a cautionary tale. This is not a randomized controlled trial. These two groups of people are not the same at baseline. In general, people who don't get vaccines of any type, so just in general, not even talking about specific to COVID, which is a whole nother ball of wax, but in general, people who don't get vaccinated also tend to have poorer health at baseline. They tend to have lower income levels. They tend to have lower education levels. They tend to have less access to healthcare or to be more distrustful of healthcare, right? So you can imagine somebody who's more distrustful of healthcare providers, they get sick with COVID, they're like, I'm not going to go to the doctor. I'm going to, I don't know, go to the vet store and get ivermectin, whatever they're going to do, right? And so they're at increased risk of death for some of those other factors aside from whether or not they're vaccinated, because these two groups are not the same at baseline. So this is the disadvantage of not having a randomized controlled trial. However, 3 times as likely, that's really strong, okay? So in terms of our supporting evidence, the strength of the relationship still persists and is still quite high. So strength of relationship using the relative risk, that is one piece of supporting evidence. Another piece is consistency. So seeing the same effect in multiple studies in different places with different groups of people. So again, we were looking at national data, New York City data, different points in time. Anytime something comes out, anytime a study comes out, we're going to want to see another study that shows the same thing before we really truly believe it, right? We're going to want to see lots of consistency. We're also going to be interested in what's called a dose response effect, because that can really support the idea that something is a contributory cause. So let's go back to that cholesterol and heart disease graph again. And you can see that the people with normal cholesterol had the lowest rate of heart disease. And then the people with like kind of the marginal cholesterol had higher and then highest, right? So the higher your cholesterol level was, the higher your risk of heart disease. So that's what we would call a dose response relationship. The higher the dose or the higher the exposure to the risk factor or the worse the risk factor is, the more likely you are to have the disease. Dose response. We can see that also with cigarette smoking. So this is lung cancer risk. Now, I just want to be clear, cigarette smoking increases your risk for lots of things besides lung cancer. So heart disease, cancers of all types. Same thing actually with a lot of e-cigarettes and vapes. So just keep that in mind. It's not just all about the lung cancer. But what you can see in this particular study is that the heavy smokers, which are these folks right here, have the highest, right, incidence for lung cancer, right? These are people who cut down their smoking. These are people who are light smokers. These are people who quit entirely, but recently. These are people that quit a long time ago and stayed quit, and then these are never smokers, okay? So again, a dose-response relationship can be very suggestive. And I just want to point out, right, look, never smokers get lung cancer too. It's complicated. All right. The fourth type of supporting evidence that we're going to look for is something called biological plausibility. So knowing what we do about how the body works, does it make sense that this could actually contribute toward a disease? So in the case of cholesterol, we know that the blockages that form in coronary artery disease are mainly composed of cholesterol. So it makes sense if you have higher cholesterol, you've got more of it around, or you're more likely to clog up your arteries and cause a heart attack. Makes sense. Biologic plausibility. We know that cigarette smoke has all types of toxins in them, many of which are carcinogens or cancer-causing agents. So does it make sense that inhaling a lot of cigarette smoke over the course of your life would increase your risk of lung cancer? Yes, those things are biologically plausible. So that's another piece of supporting evidence. Okay, so etiology. How do we establish contributory causes Or conversely, how do we establish efficacy of interventions, which is kind of the flip side? So looking at things that help protect or reduce your risk of disease, right? We're going to use the same types of data. So we're going to look for group associations to generate our hypotheses. Then we're going to see if the association persists at the individual level, usually with case control studies, looking at people who have the disease versus who don't and see what's different. Then we're going to look for the timing. Does cause precede the effect with those cohort studies where we enroll a bunch of people, some with a risk factor, some without, follow them over time and see what happens. And then requirement 3, we may not be able to do for contributory cause because that's where your randomized controlled trials really come in. So we might not be able to do that for something that makes you sick. So then we're going to look for those supportive evidence, things like consistency, the strength of the relationship, which we're going to assess by using relative risk, dose response, and biologic plausibility. Oh, and there's some animations. How exciting. So let's just remember, a contributory cause or risk factor does not necessarily determine whether or not you're going to get the condition. It just increases the likelihood that you will. So smoking increases the risk that you're going to get lung cancer. Not all smokers get lung cancer. In fact, most of them don't. Not everybody who gets lung cancer was a smoker. Never smoking is not a guarantee that you won't get lung cancer, right? It's not sufficient. It's not enough, but it stacks the odds one way or the other, right? So same thing with unprotected sex. If you have a lot of unprotected sex, you are significantly increasing the odds. You're increasing the statistical probability that you or your partner will get pregnant or that you'll get chlamydia or some other STI. Now, there's plenty of people out there who've had lots of unprotected sex and none of those things have happened to them, right? So it's complicated. It's not simple. It's all about stacking the odds or increasing the likelihood, increasing the chances that something will occur. Humans are really complicated. There's so many things going on within our bodies. There's so many things going on in our environment. And then there's just like life can be totally random. And sometimes it's just a matter of luck. So in public health, we want to understand what these contributory causes are. So then we can start to think about, okay, how can we stack the odds? If the contributory odds increase the likelihood of a condition, how can we then tilt the odds in favor of health? And so that's what the next section is about, which is figuring out what our recommendations are going to be. See you then.